Welcome to part 2 of cardiovascular. This part will focus on hypertension. Hypertension, also known as high blood pressure, is the most common chronic disease in American adults, affecting 33% of adults. It's also a leading risk factor for premature death, disability, and disease worldwide because it has so many issues it can cause if not treated, like cardiovascular disease, stroke, and kidney disease. Hypertension is also considered a modifiable risk factor for these diseases, as most people can lower their blood pressure if they change their diet, exercised, stopped smoking, and took their medications regularly. The non-modifiable risk factor that has the highest prevalence for hypertension is being an African American male and having a family history of hypertension, as hypertension can be genetic. Older age is also a major risk factor for hypertension. Other risk factors include kidney disease, which it can also cause, smoking, diabetes, alcohol use, overweight and obesity, inactivity, and stress, all of which are modifiable. The chart on this slide should not be new to you. It defines the categories of blood pressure. The American Heart Association defines hypertension as a systolic blood pressure of 130 millimeters of mercury or higher, and a diastolic blood pressure of 80 millimeters of mercury or higher. About 46% of people with hypertension do not have it under control, meaning their blood pressure is still over 130/80. In addition to these, we have primary hypertension, called essential hypertension, which does not have an identifiable cause. This accounts to 90 to 95% of the patients. Secondary hypertension is hypertension with an identifiable cause, like kidney disease, sleep apnea, or pregnancy. And this accounts for 5 to 10% of hypertension patients. Hypertension can occur as a result of increased cardiac output, or the amount of blood leaving the heart, increased peripheral resistance, or how constricted the blood vessels are, or from both. Increases in cardiac output are often caused by excessive blood volume, which could be caused by high sodium-rich diets because sodium loves water. The blood vessels in the kidneys also have a major impact on hypertension because if the blood vessels in the kidneys are constricted, it limits how much blood the kidneys can filter, which means they don't release as much extra fluid into the urine as they should. Somewhere in the body's regulation of cardiac and fluids, there's also some issue with the body's ability to regulate these. There are honestly so many factors that can affect both of these that hypertension is a really complex disease. Other causes of hypertension include dysfunction of the autonomic nervous system that causes issues with the RAS system, the sympathetic nervous system, and activates the immune system, which can cause an inflammation in the blood vessels. Hypertension has many complications associated with it as blood flows everywhere in the body. The left ventricle has to work harder to push out the extra blood or to push against very constricted blood vessels, so the myocardium gets bigger and thicker. This is called left ventricular hypertrophy. Sadly, a bigger heart doesn't make it stronger. It actually makes it weaker, which then causes the heart to fail. Hypertension can restrict the amount of oxygenated blood getting to the coronary arteries, which can cause a heart attack, which is called a myocardial infarction. Hypertension can also cause transient ischemic attacks, or TIAs, which are also called mini strokes. They can cause full-blown strokes, which are called cerebrovascular accidents, or CVA. Because of the high blood pressure being sent to the kidneys will occur damage and start to fail over time. One of the reasons why hypertension has such bad complications is most people don't know they have hypertension. They may not have any symptoms, and the only time they find out their blood pressure is high is when they go see a provider. When we assess for hypertension, we want to assess their history and their risk factors. Many people don't even know that hypertension exists, so assessing their health literacy may be helpful as well. We want to, of course, assess their whole cardiovascular system and their blood pressure, but we also want to assess for any organ damage. This can include angina, which is chest pain, shortness of breath, altered speech from lack of oxygen to the brain, altered vision, headaches, which is a common symptom of high blood pressure, balance issues, and nocturia, which could indicate kidney damage. We also want to assess any personal, social, or financial factors that may be affecting their hypertension, like those modifiable and non-modifiable risk factors. Financial factors can play a role in diet because, let's be honest, McDonald's is much cheaper than healthy food, and having to change to a healthy diet and exercise and take medications all affect finances, and some people do not have the ability to afford the changes needed. As far as diagnostics, we can do laboratory tests like urinalysis or blood chemistries to check the kidney function, specifically BUN and creatinine and electrolytes. An ECG won't show hypertension, but it can show cardiac damage that's been caused by the hypertension. I mentioned that a lot of people don't know they have hypertension. That's because a lot of the symptoms don't occur until organ damage starts, or they could think their symptoms are related to something else, like a headache. A headache could be literally related to anything, and if they don't know it could be hypertension, they're not going to get it checked out. We also have two types of hypertension that may lead to not being diagnosed. The first is masked hypertension. That's when someone who has high blood pressure goes to a provider, but their blood pressure is normal or maybe even low. Another is white coat syndrome. This is when they actually have normal blood pressure, but when they go see their provider, their blood pressure goes sky high, usually due to stress and anxiety from going to the provider's office. Managing hypertension is aimed at getting the blood pressure less than 130/80 and preventing complications. Both of these can be accomplished in most people with lifestyle modifications: weight reduction, regular physical activity, reduced alcohol intake, smoking cessation, and following a low sodium DASH diet can make all the significant decreases in blood pressure that we need. They all also require dedication, time, and effort, all of which are hard to maintain. If these don't work or aren't able to be followed, we can use medications to decrease blood pressure. We use medications to either decrease peripheral resistance, which is constriction, decrease blood volume, or to decrease the strength and rate of myocardial contraction. The first-line medications for hypertension include diuretics, especially thiazide diuretics, ACE inhibitors like lisinopril, ARBs like losartan and valsartan, and calcium channel blockers like amlodipine. Second-line treatments for people with complications or for people who didn't respond to the first-line drugs, we can use diuretics like furosemide or spironolactone. We can use beta blockers like metoprolol or propranolol. We can use alpha-1 blockers like doxazosin, or alpha-2 agonists like clonidine, or direct vasodilators like hydralazine. Now, these are a lot of medications. I listed the most common ones being used, but each category has several other drugs that can be used instead. And in some people, we may need to use several drugs from different classifications to get the blood pressure less than 130/80. Hypertension has a huge need for education. Not only do we need to educate our patient on what hypertension is, we need to educate them on the lifestyle changes they need to make to lower their blood pressure. We may need to reinforce this information many times, as they're not easy life changes to make. We need to offer them support and celebrate any changes they're able to make and stick with. They need to be educated on the complications they may develop and what symptoms they need to report to providers versus which ones require an emergency room visit. We need to do a lot of education related to the medications they're prescribed, as well as the side effects they may develop from them. We may need to find financial support for their medications if they can't afford to take them. We need to help them adhere to the treatment plan, and finances are a big reason why people don't adhere. Our patients need to be educated on attending their appointments for lab tests and with the providers, as well as be taught how to take their blood pressures at home and how to keep a blood pressure diary. And honestly, we may be repeating all of this information over and over again, and sometimes we never get the patient to change their lifestyle or adhere to the treatment plan. Another thing, we need to make sure that the patient understands that they will always have hypertension if they're taking medications for it. A lot of people will think they no longer have hypertension because the medication's lowering their blood pressure. They still have hypertension. The medication is just doing its job. When we treat our elderly hypertensive patients, we need to know that medication regimens, especially if they're prescribed multiple medications, can be difficult to remember. We may need to encourage them or their family members to use a daily pill container to help them remember to take their pills. We also need to know that these medications may be expensive. Elderly are on fixed incomes and medications cost a lot. Some people have to choose between food and medications. If possible, prescribing only one medication for hypertension, called monotherapy, may help these two issues lessen and be less likely to occur. We also need to make sure the elderly person can understand their treatment regimen, can see and read their bottles, can open their bottles, and have a reliable way to refill their prescription and get to their provider's appointments. And this is the end of hypertension.